Brigitte Fung is a friend and dear colleague. I've had the privilege of working with her for 6 years and her teams in Hong Kong and the Hong Kong Hospital Authority. And based upon work that she's had a leadership role in, she's already updated standards of care in societies in Hong Kong, also the Asian Pediatric Pulmonology Society, which is a relatively new society, which is looking to address pediatric sleep and champion it across ministries of health, leading hospital groups, and universities across Asia. So one of their first action items in Singapore at their second Congress a few years ago was to update the standards of care to address pediatric sleep to include myofunctional therapy. Thank you, Brigitte, for your work.
Okay, thank you, Mark, for inviting me to speak here to share with you what's going on in another part of Asia. So let me have a brief introduction where I come from. Okay, this is my hospital which I'm working at. It's a Kwong Hospital. It has two identities. One is under the Hong Kong government and the second one is under a charity board called Dongwha Group Hospital. So we have a privilege that people come for physio can actually receive free treatment. So that's why I always am able to recruit a lot of subjects because they can come here for free. So it was built in 1911, and we're having a major redevelopment project recently. So in 2005 years later, in 2025, we should have a new building. So myofunctional therapy, I will not speak too much about it because it has been talking about on, and it's nothing new. It was actually to be introduced early in 1873, as what Mark has just taught to us about, is introduced by Dr. Alfred Paul Rogers. So it's a non-invasive adjunct to OSA, and it's the treatment for the dysfunction of the muscle of the face, mouth, which is important for maintaining the face, the orofacial integrity. So now, don't forget that even orofacial exercise is important. We always neglect the body work. So as a physio, we look specifically at the body work. With the young man in here, he received 6 months of orofacial exercise, but the therapist there forgot about the body work, forgot to work on the core muscles. So you can see the head forward posture was not being changed. So we have to work again on the postural muscles, on the core muscles to change the alignment of the body. And after introduction of lots of exercise body work, you see the alignment is much better. Also, we should not forget about the breathing re-education, as a lot of speakers have been talking about more and more about the mouth breathing. So we know that we have to retrain the breathing pattern so as to maximize the nasal breathing. So there has been a lot of abnormal oropharyngeal features in OSA. We have to look at the tongue, the frenulum. Is the frenulum restricting the tongue? The cranial abnormality, whether there is any high arch palate, will affect the dentition. We have to check whether the child has an enlarged tonsil and adenoid. And again, the posture and the mouth breathing. All these features are interrelated with each other, and we cannot skip treating any one of them. So let's look at the assessment that we usually do with us. There has been a lot of outcome variables in the market, a lot of, say, questionnaire like snoring index, ESS, modified ESS, and also OSA 18 and blah, blah, blah. And of course, the golden rule will go for PSG, but it is a very expensive assessment too. Now, mouth breathing is getting more and more attention. There has been a lot of tests in the market to do mouth breathing assessment. Has been suggested like lip seal test, what keep water in mouth, and also PSG to define the percentage of mouth breathing during a PSG. And also we have to assess on the posture. I'll talk a little bit on how we do it. There had been a study done in 2018, and we had presented in IPSA. Mouth breathing is an acquired phenomenon, and the prevalence actually peaked from 3.5 years of age to 5. And it happened to 12% to 55% amongst children. And with normal children, the mouth breathing during sleep would be around 4 to 10% for the total sleep time. And Dr. CG has once proposed that it should be up to over 10% with mouth breathing children when we look at the PSG. So there was a study in 2015 showing that the more percentage of nasal breathing happens with lowest AHI. So the highest AHI will have more percentage of mouth breathing during PSG as detected. With a study that they look at after TNA, it was found that the AHI was actually still quite high with the group with mouth breathing, even though after the TNA. Therefore, we had a study done in 2018 looking at retrospectively, looking at the group of patients who had the TNA done. And we looked at 46 patients. And we found that the cutoff point was suggested to be 10.5% of the total sleep time during the PSG. And we conclude that in most post-op cases after TNA, the mouth breathing larger than 10.5% of the total sleep time will be 3.5 times more likely to have the persistent OSA. So it actually corresponds well with CG in his study that he suggests it should be around up to 10% of the total sleep time when we have to define mouth breathing in a PSG study. Okay, that's the conclusion. What about with the posture? We frequently observe there's a head-tilt posture with the patient with OSA. It's the anterior lines of the head to extend the neck so as to facilitate the airflow through the mouth. With head extension is considered as a compensatory mechanism which helps to increase the pharyngeal airway space. As we realize that with the group of patients with mouth breathing, the airway volume of air is actually half the size of the normal breathing pattern patients. So why there's such a head-tilt posture? Because there's a decreased activity of the diaphragm and there was a hypotonicity of the abdominal musculature. So we have a miniature study, a pilot study that we have to send a tribute to our Ferris team. We have different people organizing this Ferris team with Sylvia as a key person to drive as a driving force behind the team. We have been collecting data all over the world, looking at different tests that could have a quick detection of any oral craniofacial abnormalities. And we come up with one test to look at the posture, a quick screening tool that we ask the patient stand against the wall and we measure the area between the neck towards the wall. And we have we have totally recruited 82 patients in Hong Kong to look at the distance between the neck and towards the wall. And we found the group with the most significant result would be the age group from 6 to 12. So in this age group, we found that with the distance around 4 centimeters would actually best detect association with a significant higher nasal breathing difficulty. Which means that if we might have a quick measurement from here towards the wall, if it's larger than 4 centimeters, the child may have a higher incidence of mouth breathing. So it's a quick screening tool. But of course, it's actually a pilot, and we have to continue collecting the data to see if there's any better result. What about with the nasal patency? Why the child or why the patient has to breathe through the mouth rather than with the nasal? Here is one of the nasal inspiratory flow rates that we can check on patients because they got normal value. When we ask the patient to breathe in, we can check on the peak nasal inspiratory flow rate. And then we compare with the norm data to see whether the child has any abnormal data. Of course, nasal mirror would be another best quick tool to check whether there's any nasal blockage. What about with the assessment of the tongue? We can use the IOP, as most of the people have been using all over the world, to check on the endurance and on the strength. And also, yes, we have to check whether the patient has any lingual frenulum. We have a very good frenulum rehabilitation scheme in our hospital since baby was born. So we check the nasal, the lingual frenulum with using the Martinini score in our hospital. And with adult, we use this assessment to suggest by total Suraj, okay, to check on the range of motion of the tongue. What about some local evidence in OMT in Hong Kong? We have been presenting in our HA convention in 2018 to look at the use of OMT amongst the children and with a 12 weeks program. And we have recruited children who are older than 6 years of age, and we excluded children with moderate degree of mental retardation. And the primary outcome we used was OSA 18, and we checked on the tongue strength, the knots, the sleep-related breathing disorder, and also the modified Epworth scale. We prescribe orofacial exercise for 12 weeks, postural exercises, and also nose breathing exercises. With the results with these 44 children, we all found significant improvement over their quality of life, including OSA and SRBD, improvement over the tongue strength, the knots, and also the MESS. So what about adult? Recently, we tried to extend our group to adult. And we tried to see if there's OMT work with our adult local population as well. So it's a prospective study, which we have a collaboration with our ENT surgeons. And we include patients who are diagnosed as sleep disorder breathing with a snoring concern. That means those patients also went through some questionnaire to see whether they have any snoring problem or not. So patient has to underwent a type 2 sleep study at home to be included in our study. And they have to went through some orofacial myofunctional evaluation by us. And there are 12 weeks program. And then they have a follow-up at 1 month and 6 months on completion of the program. So this is the first follow-up study that we did in Hong Kong. And with the self-administered questionnaires, we used the self-perceived sleep quality score, the self-perceived snoring intensity and frequency, the Epworth sleepiness scale, and also a short version of functional outcome sleep questionnaire. What about with the orofacial? We check on the mouth opening using the MIO, the tongue movement also use the MOTTIP and the TRMR, which I will talk about it later. Also the tongue strength using the IOP and also the breathing pattern. What about with the maximum interstitial mouth opening, which I was talking about MIO? We use our therabite. You can see the assessment tool in here is a small cupboard, which we measure the mouth opening. The IOP for checking on the tongue strength and also on the tongue endurance. This is a very good piece of equipment that we can accurately detect on the strength, the endurance, and also the tongue movement. We have to And then also with the nose breathing pattern, we just ask the patient whether they've been using the nose to breathe at the daytime, yes or no. And then we check whether the kid the adult has any diaphragmatic breathing or not. And then they have to continue with this 12 weeks program at home, including the breathing re-education, orofacial exercises, and postural re-education and exercise. As I said before, why there's a head tilted position? Because they have a very poor diaphragmatic breathing pattern. So we have to train them to have the diaphragmatic breathing properly. Okay. A lot of orofacial exercises. Okay, so all these have to practice at home and even after our treatment. So therefore, when we ask the patient come back for our 1 month and 6 month post rehabilitation reassessment, we can see if their treatment effect could be sustained. He's trying very hard on this. Okay. So you can see this guy does not have any frenulum restriction. So this is a water puff exercise. We ask the patient to put water in their mouth and then to do the water puff exercises. Some resistive exercise for the bassignators. Okay. And this marshmallow twist to train on the lip competency. Okay. So let's look at the result. 14 subjects have been recruited. Actually, we are still continue recruiting the patients. And till now, we have recruited 14 subjects. And with 11 subjects were diagnosed at OSA. Only 8 of them finished the 6 months evaluation. Some dropped out at 1 month afterward. And there were no significant change of BMI over this 6 months period. We can see that there's no significant change with the sleep quality by using the questionnaire, but there's some improvement over the figures. Again, no significant improvement could be found with the Epworth Sleepiness score, but some improvement can be found in the figures. However, there's some significant improvement over the FOSQ, okay, over 6 months of period of time. That means the treatment effect could actually be sustained. And also some significant improvement with the MIO and MOTTIP with the tongue range of movement. So especially with the tongue length, then there's also significant improvement and over the endurance. Significant improvement over the nasal breathing before and after, and also with the diaphragmatic breathing. So we can conclude that they have a significant effect over the tongue mobility. So why there's a significant improvement with the tongue endurance? With the improvement of this tongue endurance, we postulated that the tongue is not so easy to be fatigued, and because with tongue endurance is involved with the slow twitch fiber, which is a postural muscles, it's important to keep the tongue in place even while you are asleep. So we are very happy to see improvement, a significant improvement over the tongue endurance in our study. So as a conclusion, we say that OMT actually improved the sleep quality and also over the tongue movement. What about with active or passive? A lot of people have been asking us, how do you sustain our exercise? Because patients really do not like exercise a lot. So actually there have been a lot of passive OMT in the market, like the Mild Munchie in Australia, and also Healthy Start. And all these, Froggy Mouth from Paris, and all these actually can improve the compliance of the patient, and we need further studies to justify that. Last but not the least, I would like to acknowledge my team. Actually, before, say 3 years ago, we only have only me working in the hot department to do all this myofunctional training. And now we have extended our team to 7 therapists working on it. And of course, with our other colleagues from other disciplines. And last but not the least, I would like to attribute to my mentor, Ms. Joy Moeller, who has been teaching me all over the years. And I always teach my patient using this picture, which is actually stolen from her clinic, how do you boost up the compliance to think of a way why you're doing exercise. With this little girl, she always think of doing exercise because when she's doing exercise, her foot will be as beautiful as like when my tongue is up onto the roof. So thank you, and thank you.
Thank you very much, Brigitte. You know, we've seen, beginning with science, soft tissue with Dr. Coca, and the craniofacial morphology with Dr. Ono, and shifting gears a little bit into clinical application. It's so great to see changes, profound changes in creating re-education to nasal breathing, changing the tongue posture. We're going to be shifting gears yet again here to Dr. Rakesh Bhattacharjee. Yes, question.
How much is AHI changing after OMT study?
Because the AHI, the PSG is a pretty expensive investigation in Hong Kong. They haven't quite finished with the AHI examination after the 6 months because it's always a long queue. So I can only at this point present the change in the outcome measures like the questionnaire and also the tongue strength, etc. We're still collecting the AHI figures. not available at this moment.
We're very excited about those results, though, and we have great confidence in them. So we look forward to reporting them to you. Thank you very much. So now we're going to look at this. How do we bring this into a sleep lab? How do we bring it into a hospital? And how do we bring science around that as well? So thank you very much, Rakesh, for being here.